slowly and go through the various thyroid diseases which we treat, how to address a thyroid nodule, and then we will go on to thyroid cancer and then locally advanced thyroid cancer. So these are the thyroid diseases which we treat. So today our main focus will not be on a goiter, thyroiditis, multinodular goiter, Hashimoto's disease, Graves' disease. So we are not going to talk about all these benign or conditions which we treat medically also. We will focus mainly on the thyroid nodule, how to assess and go about when you see a patient of thyroid nodule, and how a thyroid nodule becomes a thyroid malignancy. What is the progression? So we will just focus mainly on the thyroid nodule. So when you have a patient with a solitary thyroid nodule, the first thing is you take a proper clinical history and do a proper clinical examination of the nodule. Here, doing an indirect laryngoscopy to assess the status of the vocal cord is very important. Then the second most important thing, or when it comes to diagnostic tools, is a sonography of the neck. So now specifically we will look at the sonology findings and the scoring system which they use to see whether the nodule is benign or it is going towards malignancy. So the system which they use, the radiologist, is called the Thyroid system. We will, there is a slide on thyroid system, we will just go through. Now if the nodule is more than 1 centimeter in size, which has got a highly or an intermediate suspicion of malignancy, we always ask the sonologist to do a sono-guided fine needle aspiration cytology of the nodule.
Whether cystic or non-cystic? Whatever, more than 1 cystic or non-cystic?
Sometimes what happens is that there is a nodule, say of 5 to 6 centimeter. Only say 1 centimeter or 2 centimeter is cystic, but there is a solid component also. So when you do a sonography, they will be able to see where the cyst is and where is the solid component. So then they would assess the solid part, and so it is always recommended to never do a thyroid FNAC blindly. Do it under sono guidance so that you hit the proper, the tumor, not the cyst. Sometimes the whole nodule is a cyst. In that case, you do aspiration cytology, form a block, a cell block, and you can get the report on that cytology also. Treatment of a thyroid cyst is slightly different from a nodule, which we can later discuss also. So the point is sonography followed by a sono-guided FNAC. These are the two most important investigations which we would recommend.
Irrespective of the size of
the tumor, but mainly if the tumor is more than 1 centimeter in size. With tumors which are less than 1 centimeter in size also, we sometimes do a FNAC if the tumor is growing in size or if the tumor has stayed there for long and we just want to keep a baseline thing done. This is the baseline sonography, means FNAC report. So we do a FNAC even in some cases, but more than 1 centimeter in size, sonography followed by FNAC is a must in all the patients, just to be very clear about what it is exactly. So again, FNAC reporting is done according to the Bethesda system of reporting.
Correct me if I am wrong, the normal FNAC cannot 100% rule out the malignancy, right?
We will come to that. We will come to that. So that is why we ask them to report according to the Bethesda system. You know, and the Bethesda system will clearly tell you whether it
What are
is
the risks?
yeah. So that is something which is important. Thyroid function test is important to just to see whether the patient is euthyroid, hypo or hypothyroid. Again, you know, there is a very important these two lines. Serum thyroglobulin and FDG PET is never recommended for evaluation of a solitary thyroid node. Never. The other thing is evaluation of a Bethesda 3 and Bethesda 4 nodules using molecular markers are also not recommended. So there are no molecular markers you should do routine. If the Bethesda says it is 3 or 4, a clinical judgment and a risk stratification is important whether to operate the patient or not. Now we will go to the thyroid's levels or the score. Thyroid stands for thyroid imaging, radiology and data system. Okay, so this is something which is used by the radiologist. If it is a breast examination, they call it BIRADS. So in thyroid it is thyroids. The imaging, the reporting and the data system remains the same. BIRADS for breast, thyroids for thyroid. So it's a very simple scoring system. What they look at on the sonography is the composition of the nodule, the echogenicity, the shape, margin and the echogenic foci. So what they do is they have a scoring point system, point-based system, and then they add all the points, and then if it is 0 points it is thyroid 1 and it is 7 or more than points it is thyroid 5. Now basically what this is a risk stratification classification just to help the clinician whether to address this nodule or not. Okay, final judgment and final call is the clinician's call after he gets the sonography report and the FNSE report. So this is how the thyroid system works. The other thing is the Bethesda system on FNSE. So Bethesda again has 5 grades. So grade 1 Bethesda is something which is not diagnostic. So they are not able to tell us what it is exactly. So in these cases the risk of malignancy is around 10 to 15%. Bethesda 2 again is something which is again, you know, you can follow up the patient, you can keep the patient under observation, you can do repeated sonography so that you can know the increase in the size of the tumor and then you again repeat the FNSE and operate if the need is. Grade 3 is something which is very difficult to treat and the clinician's judgment then comes into picture. So grade 3 is atypia of undetermined significance. So there is some atypia, but exactly the histopathologist is not able to tell us whether it is malignancy or it is benign. So again, it is very important to do a clinical examination, to have all the picture in your clinical symptoms and picture in mind, and then you address this thing. Bethesda 4, 5 and 6 is something which is very easy. It points towards malignancy. The percentage increases if the Bethesda grade increases. So this is very easy. So if you have a Bethesda 4, 5, 6, you have to operate the patient, whether you do a partial or a lobectomy or a total thyroidectomy. You have again risk stratification classifications which the clinician would use and address the thyroid. But yes, grade 4, 5 and 6, Bethesda score 4, 5 and 6, surgery is a must. The extent of surgery, the clinician or the surgeon decides.
Another carcinoma papillary which we do not have knowledge basically.
No, I'll come to that.
Because so in this Bethesda there is no papillary.
So that is what I'm saying. So this mainly is something which tells you whether it is malignant or not. On FNSE, it is very difficult to pick up or to differentiate a follicular neoplasm from follicular carcinoma. Why? Because follicular carcinoma, you have to see a breach in the capsule. Then only you will be able to pick up and you will be able to tell whether it is a follicular neoplasm or a cancer. Okay. But papillary, usually on the FNAC, they will be able to tell us that this is papillary carcinoma. So they give a proper single line report. Okay, FNAC suggests papillary carcinoma. So it is very easy to diagnose for a FNAC, for a histopathologist on a FNAC whether it is papillary or not, whether it is benign or cancer. But follicular, they will write specifically, it shows a follicular neoplasm, follicular carcinoma cannot be ruled out. This is the report which they will give on a FNAC, on a Bethesda. So this is how the Bethesda system works. So as a clinician, what you want is your sonography and a FNAC. Again, sonography to be reported according to the Thyroid system of classification, and FNAC according to the Bethesda system of classification. So again, very important, you have a single sonologist and you have a histopathologist who are constant with you, and they are doing this routinely. Most of the centers would report in this way. Now it is sort of a protocol and standard this thing which they follow. Now we come to the most important part, which is thyroid carcinoma. So again, thyroid carcinoma is not an Indian cancer. So this is mainly prevalent in the west side. So if you see US, they top the thyroid cancer scene. In India, it is mainly oral cancer, breast cancer and cervical cancer. But yes, thyroid, you get, there is around 3 to 4% chances in 100 you will have thyroid cancer. Papillary follicular cancers. So these cancers, papillary and follicular, comes under the category of well-differentiated cancers. So when you say a papillary thyroid cancer or follicular cancer, it is a well-differentiated thyroid cancer, and treatment for well-differentiated thyroid cancer is pretty much the same whether it is follicular or papillary thyroid cancer. Now, when this well-differentiated goes and progress to poorly differentiated, then the worst scenario is an anaplastic thyroid cancer, and it is the most aggressive form of thyroid cancer. Anaplastic is something which the surgeons will not touch. If the report says anaplastic carcinoma. Medullary is clubbed along with thyroid cancer, but actually it is not a thyroid cancer because the origin is from the parafollicular C cells. It is not from the thyroid cells. But medullary, the treatment is almost the same. You need a proper metastatic workup before you do a surgery for medullary, but surgery is the mainstay. So these three cancers, well differentiated and medullary, surgery is the main treatment. For anaplastic, surgery is not the preferred treatment. Now if you see the carcinogenesis model, a normal thyroid, there is mutation of the TSH receptor and you will have a simple goiter. From a normal thyroid, there is RAS mutations and you get a follicular adenoma. From follicular adenoma, again there are mutations and you get follicular carcinoma. If there are RET and PTC mutations, BRAF mutations, you get papillary carcinoma. And this papillary carcinoma again will mutate and give rise to an anaplastic carcinoma. So this is how a normal thyroid can give rise to a goiter, a follicular or a papillary carcinoma, and an anaplastic carcinoma. So this is something which is important. You do molecular markers and target sometimes, with targeted therapy, because you have got now inhibitors, RET inhibitors to treat these patients if they are not operable.
This goiter can transform into single nodule and malignancy.
Yes, the chances of a thyroid nodule going into a malignant this thing is very less.
I am talking about simple goiter.
Simple goiter. If it is a simple single nodular goiter, the chances of that nodule developing into a yes, again multinodular goiter, the chances of malignancy are very less. Very less.
Very less.
Yes. So multinodular goiter, if you have, the treatment is surgery, but the chances of that multinodular goiter becoming a cancer or developing into a thyroid carcinoma is less. If you have got a single nodule, then the chances are higher than a multinodular.
પછી આ તમે જે FNAC કરો એમાંથી આ માર્કરને આધારે આગળ ના કરો.
No, marker you have to have a biopsy. So you have to have a cell block. And એમાંથી IRC પર markers થાય. So you have to get a immunohistochemistry done to get to know the markers whether they are positive or negative. So on FNAC it is very difficult, but sometimes some centers they do a cell block also, and then from that you can do a IRC. But if you give a biopsy or a proper tissue to them, it becomes very easy to do all the markers because they require a good chunk of tissue to run through all the marker data. Now if you see the stages of thyroid cancer, where you have localized thyroid cancer, where around 68% of the patients would come under this category. Regional meaning the lateral neck nodes and the central compartment nodes are involved. Around 25 to 30% will fall in this category, and 4% of the patients would have distant spread when they present to us. Now if you see the anaplastic, we usually do not touch the patients unless it is a very small anaplastic which we don't get, and it is just limited to the thyroid gland. Sometimes they operate also, but we have not seen patients of anaplastic coming to us with that sort of tumor or stage. Now we come to our locally advanced thyroid cancer. When you call a cancer locally advanced is if there is a capsular invasion, then also the cancer is labeled as a locally advanced cancer. If there is extrathyroidal extension, which you can see in 10 to 50% of patients, then you call the cancer as locally advanced. And if there is lymph node metastasis in the lateral neck, then you call the cancer locally advanced cancer. Distant metastatic cancers, you can have mets in the brain, lung, bone, and again you can have involvement of the lymphatic vessel, that is lymphovascular invasion, in some 60% of cases. Again, this is labeled under the distant metastatic. So this again, if it is a well differentiated cancer, we would operate these patients. So a thyroid cancer, even with a distant met, we would still operate the patient because you have a backup of radioiodine therapy after surgery. So you remove the total thyroid gland and then you do a radioiodine scan and treat the patient with radioiodine therapy, and these things will be taken care of. For brain, you will require again external beam radiotherapy for brain mets. We will come to the radioiodine part later in the talk. Again, when you talk about extrathyroidal extension, mainly the thyroid cancer will extend anteriorly, so it will spread anteriorly. So what it will involve? It will involve the suprahyoid muscles. So the sternohyoid, the sternothyroid, the thyroid muscle. So it will involve all the suprahyoid and infrahyoid muscles when it extends or when it spreads anteriorly. So this is one extent which is important. The most important extent for a surgeon is the lateral extent or the posterior extent of the tumor when it involves the structures in the tracheo-esophageal groove. So mainly the important structure in the tracheo-esophageal groove is the recurrent laryngeal nerve, the trachea, and the esophagus and the pharynx. So when it involves these structures, this is something which the surgeon is worried, and it is something which is challenging to a surgeon, not this interior thing. This is easy to resect. This is sometimes challenging. Now we will just go through one case which we treated recently. She is an elderly female presented with us with this left sided lateral neck nodes and a right-sided thyroid mass. She had no pressure symptoms, in the sense no change of voice, no difficulty in swallowing, anything. So no pressure symptoms, just this lateral neck nodes and a right-sided thyroid mass.
Most of the time these people are having local symptoms, no systemic.
No, sometimes you will have a pathological fracture here, and then you
It is advanced.
retrospectively, so then you say okay, this is a met in the femur, but the primer is in the thyroid. So sometimes, but these patients usually have lumps in the neck or the thyroid, and they present to you. So we
कोई
did
एज स्पेसिफिकेशन था कि आई के अंदर फॉलिकुलर रिपेलिएशन
So there is a classification, there are multiple classifications given by American Society of Thyroid Society, the MSKCC classification, in which age is a very important criteria. So if it is less than, now initially it was 55 the cutoff, now it has become 45. So if the age group is below 45, the MRI image of the patient. So we decided to operate the patient. We did a total thyroidectomy with right-sided neck dissection and with a central compartment clearance. So central compartment is the node which is in the center. These are lateral nodes, these are central nodes. So below the thyroid gland, just on the sides of the trachea, you have the central compartment nodes, which is the first echelon. When the thyroid cancer spreads, it spreads in the center. This is the vagus now. This is the common carotid artery, the external carotid, the internal carotid. And this is something which is the TO group. We had to cut the recurrent laryngeal nerve in this patient because the recurrent laryngeal nerve was like this, the tumor was almost engulfing the nerve. And there was this central compartment node which was sitting here on the nerve. So we had to sacrifice the ipsilateral recurrent laryngeal nerve in this case. In well-differentiated thyroid cancer, you can always sacrifice the structures. We have cut the carotid also, dissected the mass along with the carotid and put in a graft also in some patients. So you can always do this thing if it's a well-differentiated thyroid cancer. If it's a poorly differentiated or anaplastic, you don't touch the patient. So then the patient will be called after a month to treat that residual tumor. Sometimes the tumor is very small, so you have just left a small sort of thyroid gland near the parathyroids. So that will be picked up by the radioiodine. Sometimes this low dose scan, the dose of this iodine is able to treat that small lump of the thyroid tissue. If this iodine scan is showing a good uptake, meaning the tumor is or the residual tumor is there 1 centimeter, 2 centimeter, then they will require a high dose iodine scan and they will call the patient again, prepare the patient and then deliver a high dose iodine therapy. So that is how the iodine thing works. So all well differentiated thyroid cancer, locally advanced, extrathyroidal spread would require a follow-up iodine scan after 1 month. Once the iodine scan after surgery is normal, then they don't require iodine scan in future. So this patient will not require iodine scan now. Now she will be followed up only by the thyroglobulin levels. The thyroglobulin level should be less than 1. If the levels are less than 1.1, then the patient does not require any other investigations. You put the patient or you just put the patient on a thyroid replacement therapy, so she will be on entroxin lifelong. And you measure the thyroglobulin levels every 3 months. If the thyroglobulin levels show a rise, then you require investigate the patient, so you do a sonography in the first instance. If the thyroglobulin levels are raising, if they show a raising trend. So this is how you treat a locally advanced thyroid cancer. This is how the patient was after 2 months, a reasonably good scar, This is all radioiodine, post-radioiodine treatment, scarring and skin changes which happen. So after 3 months, so thyroglobulin levels we will check every after 3 months.
Sir, shall we also check anti-TG in this patient? As and when we check TG,
No.
it will not affect the TG level.
No, only a thyroglobulin level is something which is important to you.
Patient might have developed anti-TG. Will it affect the TG level?
No. So usually what happens is most of these patients, the thyroglobulin level, if it is normal, if the patient has no symptoms, we don't do anything. And I have seen, we don't do anti-TG level. All these things are done if the thyroid gland is there. In certain benign things we do it, but for malignancy, this is something which we follow. So this is again a case, a second case which we just treated. We have not started treating. We had this patient around 10 days before in our OPD, and he came with in the emergency with stridor. Luckily, the patient was carrying a CT scan with him, which he had done in this private hospital somewhere in Kutch. So if you come down, you can see the tracheal involvement and the lumen here. So he was not able to breathe at all. So we did an emergency tracheostomy because luckily the patient had a CT scan. We were able to see this space here. So we did an emergency tracheostomy. And then after an emergency tracheostomy, we did a DL scopy biopsy. This was the tracheal involvement. So this is the interior of, this is a DL scopy, a direct laryngoscopy picture. These are the vocal cords and this is the tracheal and the glottic involvement which is seen here. So we did a biopsy from this tumor which came as features suggestive of anaplastic carcinoma. So this is something which we did. So this is how the trachea gets involved. This is this and this. And even this, all this, if it is well differentiated cancer, we would still operate. So we still operate the patient, and what we do is we resect the tracheal rings, and up to 4 to 5 tracheal rings, you can pull the trachea and do a anastomosis for 4 to 5 rings. So if the tumor is involved in the tracheal rings, you can resect the trachea, do a mobilization of the trachea above, do a hyoid draw, and then you can anastomose the trachea up to 4 to 5 rings. Okay. But the thing is, it should not be an anaplastic or a poorly differentiated cancer. It should be a well differentiated cancer. If the need be, you can remove the trachea and anastomose. So, but for anaplastic CA, we don't do this. We are working up this patient, and then we will subject this patient to external beam radiotherapy and some palliative chemotherapy. There are lots of other targeted therapy also for anaplastic CA, but you have to run the molecular test and you do the markers, then only you can do target those molecules and cancer. So thank you everyone for your patience.